Okay, welcome everybody to the MGH brain-PBM clinic rounds. It is today, April 23rd, 2021, and it is, I'm Paulo Casana. It's my great pleasure to introduce our presenter today, Leon Morales-Quezada, MD, instructor in physical medicine and rehabilitation at Spalding Rehabilitation Hospital, who's going to present today a case of combined treatment approach for epilepsy in a child with autism spectrum disorder. So welcome, Leon, and please take it away.
Thank you, Paulo. Thank you for the invitation, and thank you everybody for attending this presentation. As an initial disclosure, I'm relatively new to the field of photobiomodulation. I'm coming mostly from the neuromodulation field, particularly non-invasive brain stimulation and peripheral stimulation as well. But what I'm going to present is a case that it actually had a deep impact on me, particularly as a clinician, and how it just basically took me to what we are doing now in some research at Spalding. So I'm based on Spalding. I'm the director of the Integrative Rehabilitation Lab and also associate director for the Spalding Neuromodulation Center. The case that I'm going to present is from the Center for Neurological Rehabilitation of the in the School of Medicine in Valladolid in Spain. So this is my ongoing industry-sponsored research. The one that is relevant here is the one from Erconia Corporation, because we're receiving support from them, and you will see this. And we received a grant a couple of years ago from the US Air Force to help to design optimization in the electrodes for transcranial direct current stimulation. So because I'm going to talk about that, I'm disclosing this. So here we are. Let's start with our case. This is Hope. This is the fictional name for this patient. When I meet her, she was 5 years old with the past medical history of hypotonia and infantile spasms that presented to our unit basically to seek an evaluation and treatment for the neurodevelopmental delays that she was presenting, and also this epileptic activity, but more important, the irritability. This girl, just as the moment that she went into the office of each of the professionals that were evaluating her and treating her, it just came a miserable girl, just crying, very, very difficult to handle. So this had a really impact in any of the techniques that parents tried in the past, the doctors tried in the past. This family is living in Madrid. Valladolid is north of Madrid, so it's 1 hour drive, 1 hour by train, or 3 hours drive. So in their home in Madrid, it was basically she was not receiving any form of therapy because her behavioral problems. So her illness really started 2 years ago, previous to our first consultation, with staring spells characterized by this typical backhand expression and decrease of muscle tone, particularly in the cervical area. So she tended to drop her head when she showed this. These episodes were short in duration, sudden, and it also finished without any much changes. Every time Hope was exposed to emotional distress, or she was sick, obviously the frequency of these seizures increased. And despite the fact that she was placed on pharmacological treatment, she didn't have adequate control of this. And because of these clinical issues, obviously, the implementation of any rehabilitation efforts, it really didn't work. It was very difficult for any therapist, physical therapy or speech therapy, even horse therapy was difficult for her. So she was a prototypical crying baby with sleep problems. And these problems really got worse when the parents decided to adopt another girl. a newborn. So it was kind of interesting to see that this kind of competition for the attention of the parents, it also was present in Hope, despite her neurological problems. And there was a point that parents were afraid to put together Hope and the new baby because she would become not only irritable, but also aggressive towards the new sister. So in the review of her system, she was a little bit chubby. It was a chubby baby, basically because she had compulsive eating, sorry, poor sleep quality. She tended to wake up very frequently. The gastrointestinal level, her belly was a little bit bloated, mostly because of excess of gas production, and that had produced also abdominal pain. She was fluctuating between periods of constipation and diarrhea, mostly dependent on what she was eating in these compulsive behaviors, trying to put everything on her mouth. If they left her alone on the kitchen and there was a an onion over the table, she would take the onion and start biting the onion. Um, and skin and hair, she was diaper rash, disseminated ectopic disease in her body. We know that the gastrointestinal issues, at least 7 out of 7 children with autism, they have problems in eating and feeding. And this obviously supported this link between gastrointestinal and behavioral problems in autism. Epidemiological studies have shown that there is a strong correlation between the risk of autism, either the maternal or infantile atopic disease, like eczema, food allergies, or intolerances, mostly because the relation with or the involvement of the activation of mast cells. Uh, these cells, which are unique tissue immune cells, are located perivascularly almost everywhere, but also in the central level, the hypothalamus and the thalamus. And there might be some correlation also with the difficulties in regulating emotions. Uh, Neurologically, obviously, there were the main problems there. And when the parents received Hope, she was 3 months old. And it was clear that she had some problems, hypothonia, and then these involuntary movements, later categorized as infantile spasms. Later on in Spain, she was diagnosed with 15q duplication syndrome because the clinical characteristics, she received ACTH, the standard treatment for infantile spasms. Later, they moved her to vigabatrin. It was clear that she was developing neurodevelopmental delay, poor language production, constant crying and irritability. Her gross motor functions, the milestones were getting behind. She started really walking independently until she was 2 years and a half. She presented stereotype behaviors, stereotype lutherans, body rocking, clapping, and what I mentioned before about her compulsion to put things in her mouth. So let's make a little break here about this 15q duplication, which is basically the presence of at least an extra maternally derived copy of the Prader-Willi Engelmann critical region in the chromosome 15. Particularly is the region 11.2, the one that is duplicated. And this extra copy most commonly arise by two possible mechanisms. The maternal isosedentric duplication, or in some cases triplication, or the maternal interstitial. Those with the maternal supranumerary or extra chromosome are more severely affected by this disorder. Kids with the duplication 15q usually present with hypotonia, motor delays, intellectual disability, autism spectrum disorder, epilepsy, including obviously the infantile spasms that Hope was presenting. But something that separates these kids from other autistic kids is that Hope was responsive to some social smile, and particularly when you try to interact with her. So this kind of particular behaviors in kids with 15q duplication syndrome compared to children with have non-syndromic autism. These children with the duplication demonstrate this distinctive behavioral profile. So what we have here, this will be, let me see my pointer. Can you see my pointer now? Yeah. So this will be basically a kid with a normal karyotype. We have the two chromosomes, the one from the father, mother. This will be the duplication of the 11.2 region. It will be here. That's basically the one that Hope had. And this is the isodescentric triplication, which is basically an extra copy of the whole chromosome plus the duplication of the region. And as I mentioned before, is kids who present this, they have worst clinical picture and obviously outcomes. So there are few studies showing the implications of this chromosomal abnormality in kids with autism. So, but here in this nasal stain cerebral hemispheres, we can see that most of the abnormalities are being expressed in regions, for example, the anterior cingulate cortex, the prefrontal cortex, the front row insular area, amygdala, hippocampus, cerebellum, but we can focus here in the frontoinsular area that is relevant in this particular case, and I will show you how, but because it seems that in this case, or these few cases that have been reported, we can observe this pattern of the von Economo neurons. The von Economo neurons are a particular set of neurons that are involved in the evaluation of complex environments, particularly social interaction. So in the case of kids with the duplication 15q syndrome, these neurons, they are abnormal in shape. The morphology is different. They adopt this crook-wise or spiral-like morphology with an increase in the size of the nuclei. Because usually these neurons, the von Economo neurons located in the frontoinsular area, they tend to be an elongated neurons. A functional von Economo neuron will be elongated with long axon and a projection of the dendrites following the projection of this axon. So the morphology is different. So we can say that it's a wine cork shape, if you want to see it. Interesting to see is the increase in the volume of the nuclei, indicating somehow an increase in the metabolic rate of these neurons. However, this metabolic rate is just totally inefficient, because if we accept that these neurons are very good modulators of behavior, with this aberrant behavioral pattern of irritability and lack of social interaction, is not responding very well to the function of these neurons. Clinically, what we can observe is this. This was what basically gave us the diagnosis for the infantile spasms in Hope, the presence of hypsirhythmic activity on the EEG, which is consistent of diffuse giant waves of high voltage, above 400 millivolts, all over the places, a disorganized trace. In a series imaging studies that was performed actually from Mass General, they present these kids that they have, in some cases, hippocampal sclerosis, and also some malformations here. Heterotypias are also typical in these cases. And in the only MRI that we were able to evaluate in Hope, this is when she was 3 years old, it was reported that there was a decrease in the volume of the corpus callosum and also the hippocampal structures bilaterally. And there was a lack of white gray matter differentiation around the perisylvian fissure, very close to that frontoinsular area that I was talking before. So I don't know if you can see very well here. I have a bigger screen in this way. So if you see, this will be the white matter in gray, obviously the gray matter, and then you see how we basically lose them here. This will be a cortical heterotopia, very characteristic of a hyperexcitable tissue, and in most cases, in some kids, were very well identified, very well localized. If they are detected very early in life, they can be resected, that they can be removed with epilepsy surgery, and most of these kids, they will have a good outcome. In this case, although this was maybe the best picture of the heterotopia in the pericillian future, we assume that there is in some other places as well, particularly closer to the hippocampal structures. At this point, we really didn't want to go through another or look for another or more recent MRI. It might be something to consider later in the future for this girl. Uh, Her past medical history was basically relevant for now the diagnosis of absent seizures after those initial spasms. Then the first 2 years of life, it weren't normal for her. So parents, yes, reported that she was a crying, irritable baby, some abnormal behaviors. There were obviously some movements that were very suspicious of epileptical activity. But when she was 3 years old, she really was diagnosed by the electroencephalography by having absent seizures, and she was initially treated with valproic acid, later ethosuximide, which increased the irritability. At that time, the treating epileptologist, it was concerned that it was the side effect of the ethosuximide, mostly headaches, the ones that triggered the increase on irritability. When I saw her, she was on lamotrigine, 20 milligrams per day, with relatively good control, and she was also taking melatonin at night just to help her to sleep. Um, this is what it really shows some of the main problems in the history of this girl. Hope was adopted when she was 3 months old. The plan was to adopt her as soon as possible as a newborn, but the process was very difficult, administratively problematic in her home country, in Ukraine. So the parents really didn't, the adopted parents didn't really have a time to take her early in her life, and then at least to expose her to a more adequate medical treatment. So those initial 3 months of life are kind of a blank episode in her history. They didn't receive much information from the authorities in Ukraine. What we know is that both parents, the biological parents, who had history of drug abuse, drug and alcohol abuse. Mother was diagnosed with bipolar disorder, and the two older brothers of this girl of Hope, the two of them, they had autism. So just by knowing these antecedents, knowing this history, any pediatrician will be quite curious to be a little bit more concerned about the possible implications of this history on the baby. As I mentioned before, it wasn't until they arrived to Spain, in Madrid, when they noticed that she was having these abnormal movements, that she was a flaccid baby, a hypotonic baby. They took her to the pediatricians in Madrid, in the main pediatric hospital, and they did the diagnosis. It was a difficult physical examination. Our nurses, they reported normal vitals, which I want to believe that. I mean, she obviously was stable. What was clear that she was pale, very irritable, uncooperative. The moment that she went into the clinic, everybody noticed that. The Center for Neurological Rehabilitation in the School of Medicine is in this old building. I mean, these are old buildings with high ceilings, long corridors. So there is echo everywhere. So her crying, her how loud she was, it was people in different offices, they knew she was around. They knew that Hope was in the clinic. She had a prototypical feature, a facial feature, flattened nasal bridge with short upturned nose, which has been described in kids with the 15q duplication syndrome, eczema on her cheeks and neck. We talked about this atopic dermatitis. The abdomen was soft but distended, and there was a lot of bowel movements because the gas production, diaper rash, her extremities, the muscle strength was low, hyporeflexive as well, very poor fine motor skills. She walked with a wide base. And overall, this examination, it needed to be done in the lab of the father. She had a better attachment with her father. So every time that we tried to do something was with her father. And this is when things start getting a little bit more complex in this case, because not only Hope was suffering, her parents were suffering. These were tired parents who couldn't sleep at night because Hope couldn't sleep. Now with the new baby, which was a newborn at that time, they also were now taking care of her. And then there was this disjunction between the father and the mother, even considering the mother considering to put Hope into an institution. The father didn't want to go that way. The father really wanted to basically rescue Hope before thinking to send her to an institution. And basically that was to the point that they said, we were willing to do anything. They talked with the neurologist in Madrid. They know about us, particularly our approach with the multidisciplinary team, but also with non-invasive brain stimulation. So that's why she was referred to us. Her blood work, some borderline anemia, something that is also quite characteristics in these kids is a subclinical hypothyroidism, and also some low levels of vitamin D, particularly because she's also taking the anti-epileptic drugs. So all of this was the abnormality on her. In our side, and well, the clinical EEG, what it shows is obviously an abnormal study with the presence of a slow activity, a non-discernible background rhythm, increased rhythmic beta activity in the frontal area of her, or in frontal lobe, and ictal activity in the temporal area, particularly the spike and wave shape. So in our center, we do not record the traditional clinical electroencephalography. We do a short electroencephalography. When I'm talking about short, it's about 5 to 6 minutes, eyes open, eyes closed. Obviously, in this kind of cases, is very difficult, but fortunately, our technicians are fantastic. So we were able to get a very decent trace where we can see here this, I don't know if you can see very well, but this will be the F4 right frontal area of the brain. We see this burst of high activity, fast activity, beta activity that was previously reported on the clinical EEG. But we use this trace basically to perform the signal analysis and obtain what we call the quantitative electroencephalography. So what you see here is the brain mapping, as many people call it, of Hope's brain that is derived from the traditional EEG signal, transformed by mathematical methods into these topographies. Here we will have each oscillation of the brain from delta activity, the slowest one to the fastest one, high beta, gamma activity in that range, and the properties in the absolute power, the relative power, and asymmetry. And something that is clear is here in this heat scale, The blue is a lack of, reddish will be excess of, and these are based on standard deviations. So the absolute power of the background rhythm is inexistent. She didn't have any alpha activity coming from the occipital area of her brain. There was no gradient that was observed posterior frontal. It was in the two analysis with absolute power and the relative power. But also we move a little bit beyond of that, and we apply what is called the low resolution brain electromagnetic tomography, or LORETA, which is a method for localizing electrical activity in the brain based on skull potentials from the electrodes that we are recording. And this method solves what is called the inverse problem, which basically is to convert measurements or signals from the EEG into information about the physical object, in this case, the brain, assuming the brain is spherical. We know the brain is not spherical, but it's a very good approximation. It has been used by many neuroscientists. It's been applied also in some clinical conditions. So we consider it as a source generator. And by applying the quantitative EEG and also the spike detection, we notice parietocentral activity, ictal activity here, you see it, and also a right temporal spike over here. So with the previous antecedents from the heterotopia that were observed on the MRI, the clinical characteristics of the absent seizures, which usually mostly come from the hippocampus, it helped us really to design the type of montage that we will use for the electrical stimulation. So to summarize the case, Hope is 5 years old with a history of hypotonia and infantile spasms, which later was diagnosed with the duplication 15 syndrome, now has epilepsy and obviously autism, this abnormal, the chromosomal abnormality is obviously the thing that is producing all of these symptoms. We decided to accept her in the program, which is an intensive rehabilitation program that it consists of 3 weeks. We refer her for nutritional and endocrine consultations because that hypothyroidism and the low levels of vitamin D, physical and speech therapy, cognitive and sensory stimulation, and in my case, the non-invasive brain stimulation. The technique that we use or I use was transcranial direct current stimulation in epilepsy, which we have some experience with that. We know, I'm not sure how much familiar you guys are to tDCS or transcranial direct current stimulation. I hear in previous presentations people talking about tDCS, so I'm assuming most of you have some knowledge about this, but just a quick refresher, the effects of the stimulation are polarity dependent. And when we use 2 electrodes, usually an anode or a cathode, the anode stimulation will facilitate neuronal activity by modulating at subthreshold level the membrane potential, and cathodal stimulation will produce inhibition by making more difficult the firing of the neuron. All of these effects are subthreshold as opposed to other stimulation techniques like transcranial magnetic stimulation that they really trigger action potential. So what we know of tDCS, particular cathodal stimulation with tDCS, is that it decreases cortical excitability. It's a very good technique, it's safe. We've been using it a lot in the Neuromodulation Center, in a clinic that we used to have in Spalding, in this clinic in Spain. It's quite safe, it's easy to apply, as opposed, for example, with TMS that require a little bit of more skills in locating the hotspot or the targeted area. What I really like is that we can create personalized protocols based on neurophysiology, and I'm going to show you this a little bit later. And it's a fantastic tool when you combine with other therapies. So for example, in Spalding, what we did a lot was to do the stimulation while the patients, particularly kids, were exposed to the Locomat, to the robotic therapy. The results were very, very good. But also we have done some research. We were among the first group in collaboration with my colleagues in the National Institute of Neurology in Mexico City, we were the first ones to report effects of cathodal stimulation on mesial temporal lobe epilepsy in patients with hippocampal sclerosis. So here we tested three conditions, the sham stimulation, 3 days of therapy or 5 days of therapy. There was a clear benefit of the stimulation. There is also a clear placebo effect, which we were expecting. However, in the follow-up, we observed that effects of the stimulation were more predominantly on the active group than in the sham group. So this kind of response is typical when we observe when we do clinical research with medical devices, that there is a huge placebo effect in the beginning because the expectations to the treatment, everybody is more motivated because the medical device, the medical technology has on the expectations. But then we see this separation between the groups. And then later, different groups around the world, they start replicating our studies. So when there is a well-defined area that we can really target with tDCS. So far in our research, and my colleague from Mexico, Daniel San Juan, now is expanding really his research in epilepsy and cathodal tDCS. We also presented in the line, the International League Against Epilepsy. There was some interest, and at least I know there is a company that is interested to do a multi-center trial looking for the FDA approval. So let's see. Also, something that we are familiar with is, and this is where my support from the US Air Force came, is because in collaboration with the Air Force, we were designing electrodes and montage that it helped us to better deliver the electricity, right? The electrical field into the tissue. So what we did was basically to create a phantom head, a 3D phantom head from scratch. We create this fake head. And then in the process of producing this head, we inserted electrodes at different levels of this phantom in the white matter, in the gray matter, and in the scalp. Something that has been shown in different studies is that most of the voltage and electrical field is trapped on the scalp because of the high resistance of the skin. And despite that, there is a penetrance of the electrical field and the voltage in deeper structures, all the way to the white matter. And then we replicate the same kind of idea, but now this is the phantom head. This will be in a group of healthy subjects. Instead of implanting the sensors inside this phantom, here we use traditional 64 channels electroencephalography, and we try to observe the difference in the spectral power density of the EEG. This is also quantitative electroencephalography, pre and post, when using a particular electrode, this circular electrode that was designed by the US Air Force. It really not only showed that has a deeper penetrance in the tissue, but it also showed in the human model that it modulated the electrical activity of the brain. These are changes in the low alpha bandwidth from 7 to 9 hertz on the EEG. It was modulated. This is pre, this will be post. Again, blue will be a decreased power of this particular brain oscillation. In this case, at least in the frontal area, F3, AF3, it really, when you compare the traditional montage that use the rectangular sponges against this special circular electrode, that it really helped not only to penetrate the tissue based on the phantom head, and then this will be the computer modeling of the phantom head, but also in the EEG-based modeling on human brains. So this was Hope's brain stimulation protocol. We started with 10 sessions of high definition tDCS, and high definition is because the type of electrodes and also the montage that we use over the right temporal area. And then we just switched to the other side because this were bilateral activity that we were recording, mostly predominant on the right side. We started with 10 minutes of stimulation, building up to 20 minutes, and from 500 to 2 milliamps in a gradual way. Just for safety, we all the time tend to monitor simultaneously the EEG. Based on the EEG, then we can create a simulation in the program that we were using that will help us to identify better the targeted area and also to locate the electrodes that we want to use for the stimulation. So based on the analysis that we do and based on the capabilities that we have now in the software of the systems, we were able to identify the best montage. And also, this is not her head, but this is the head of a kid with her the same age, and also it was a girl. We were able to use it as a reference to create the best possible solution for the optimization of her EEG. So you basically, based on the MRI, because we didn't have the recent MRI, but this was a referential MRI, you can basically construct anything from the skull, the CSF, white matter and gray matter and white matter. And based on that, you just run the models, and the models will tell you what will be the best montage in order to reach better penetrance. So the montage that we selected was based on this optimization, and at least based on the modeling and the EEG based modeling, it shows that we will have a deep penetrance, at least that will reach the deep temporal structures. So, okay, this is quite fancy and sophisticated, but what happened clinically? Well, clinically, what happened is this decrease on seizures. This is recorded by the parents. They have a diary. We always ask them about how to record, and we teach them how to record the seizures, how they use also now the advantage of technology, the cell phones, the smartphones used to record video. The first 5 days, these are not stimulation. I'm sorry I couldn't put a negative value here. These are the 5 days prior to the stimulation, just to get an idea of how her ictal activity is overall. We can say that she has an average of 7 to 10 seizures per day. That was basically consistent, the one that parents reported in her life. Here is when we started the stimulation. So this day we start the cathodial stimulation. Something that is becoming more clear, at least in my clinical experience, is that after the first initial session, there is an increase of seizures, that it might be just a reflexive activity from the foci. And then is when we start, after that, after the second stimulation, is when we see this pattern of decreased activity. So this is great. This is great for the seizures, right? And tDCS. It didn't surprise me a lot, because in my experience with other, in the research and with other cases, this is kind of the pattern that we observe, a decrease of the seizures. And this decrease of the seizures, particularly in the rehabilitation setting, it helps the kid to go and work better in physical therapy and speech therapy. Kids are more attentive, they respond better to commands, they sleep better as well. So this is the kind of things that we expect. I need to say, this is an off-label intervention. It's not approved, nor in the United States, nor in Europe. In Europe, the tDCS is approved for pain, migraine, and depression. And Canada is also approved for depression. Here in the United States, there is not approval. Neuroelectrics got, which is a company from the device that we are using in this case, they got emergency clearance to start researching home-based tDCS for depression. But in this, in Hope's case, this is an off-label intervention that was agreed between our medical team and Hope's treating team in Madrid. We were in contact with the neurologist in Madrid. These are neurologists from Niño Jesus Hospital, one of the top pediatric institutions in Spain, and they agreed. They didn't have much options, so they said, "Yes, go for it." So this is an off-label intervention. Okay, this is neuromodulation by non-invasive brain stimulation. And where is photobiomodulation coming from? Well, prior to this case, I didn't have much experience with light therapy, laser therapy. When I came to Spalding uh, 8 years ago, 10 years ago, Rosa Font, the chair of the department, I knew he was doing some research in TBI and LED, but then later on, I'm not really sure what happened, but my experience was limited. A colleague of mine from Israel, she was the one who really introduced me to photobiomodulation, because in Israel, they were having these very pilot studies in a variety of neurological conditions. Jerry Lisman, or Professor Lisman from the National Institute of Brain and Rehabilitation Sciences in Haifa University was using it. And he used it in a couple of autistic adolescents with good or positive results. And then in collaboration with people in Cuba, they have a small clinical trial. And in Cuba, they also reported positive results in kids and adolescents with autism. However, they observed a deeper impact of the photobiomodulation by low-level laser therapy in the younger kids. And they speculated that it was either the increase of mitochondrial activity or energy production, the activation of transcription factors that help the cell proliferation and migration, and even considering the anti-inflammatory effects of photobiomodulation as responsible for the effects that they observed in this study. And the results are impressive. I mean, when you see this type of results, this is in the ABC, the Aberrant Behavioral Checklist scale. This will be for the subscale of irritability. This is the active group. This is the sham group. It's impressive that there is not a placebo effect here. And they noticed that there was a clear effect of the intervention, that it lasted. I don't remember if it was up to a month. Yeah, I think it was up to a month. So these results were really impressive. And when I was talking with Jerry about this case, he said, well, why you don't try this? He lent me the device that was used in Cuba. So what we did with Hope basically was to replicate the protocol that they use in Cuba. These are the characteristics of the laser, and this is the device that we use. It's a handheld device, which is actually quite convenient because you don't need to basically hold the kid tight like other techniques. tDCS, we just use a cap, so the kid can somehow freely move around with the cap, but here the operator of the person that is delivering the light or the laser, it can move with the kid, obviously having the eye protection. And these were the areas that were exposed to the laser, are exactly the same areas that they use in the Cuban study. Bilateral temporal areas and the occipital part of the head. So that was basically the irradiation territory that we use to deliver the photobiomodulation by using laser. So the clinical response, this was what happened. So seizures were basically recorded with the seizures diary. Irritability, we didn't really have time or the patience with Hope to do a standardized kind of testing. So what happened here is we asked every single member of the staff, the PTs, the speech therapists, the nurses, just to rate Hope irritability in a BAS-like styles from 0 to 10, 10 the worst, 0 the best. And usually, at the end of the day, we just have like a short meeting with all the medical staff just to evaluate each kid, how they perform during the day. It was kind of a good agreement between personnel that, yes, she's too irritable, now she's changing. So basically using this BAS-like irritability scale from the medical staff, we also start reporting this decrease in irritability. Now, this is the time that we start the stimulation. We repeated the protocol that they use in Cuba. So it basically 2 stimulations per week, sort of. So here we have the days that we use the laser. Here is when we started the stimulation, 2 days after we started the brain stimulation. And these are the changes in irritability. It was clear that something was happening. Now, these results are confounded. We don't know who is who. If this is just the effect of tDCS, who also lead the behavioral improvements, or vice versa. It's obviously, this is a clinical case. We needed to take it like that. It's an anecdotal experience, anecdotal information, but something happened here because everybody noticed that. The PT was working better. I mean, she reported that Hope was collaborating with her in some of the exercises. The speech therapist was also very happy. The cognitive therapist was also happy. Everybody was happy about the third exposure to the laser. What really, she really started going down. Quite. This day, I think she had a diarrhea. So this is why she got a little bit more irritable. I remember we were thinking about an infection. It was just the diarrhea, nothing else. But at least the clinical picture improved dramatically, both for seizures and irritability. And for the first time, parents, particularly the mother of Hope, she was kind of happy with the conditions and the state that the girl was at that particular time. More important, they were able to sleep. This is what happened clinically. We also observed objective results. We observed that the quantitative EEG show, by the first time, the presence of the dominant posterior rhythm. So here we were 3 points over the standard deviation. So here we start observing these changes at the occipital area that were also identifiable on the raw EEG or in the regular EEG trace. Later on, when she finished the program with us in Valladolid and she went back to Madrid, they recorded another clinical EEG, and they also reported an increase in alpha activity in the posterior side in the posterior pole, which in any kid with neurodevelopmental delay or neurodevelopmental condition is an indicative of things that are getting better. When we start observing this high theta, low alpha in kids at that age, 5 years old, that they didn't have previously. And when we start observing this pattern of activity, we can say at least her brain is organizing a little bit better. So based on this, we can say that the combination of the 2 techniques had a positive effect on the seizures reported by the parents and the irritability reported by the medical staff. But more important, there were no observable side effects. And Hope tolerated both techniques quite well. The mechanisms behind this modulation of symptoms, particularly for the low-level laser therapy, have been hypothesized to be related to the facilitation of cell and neuronal repair, as well brain network rearrangement, upregulation of trophic factors, and neuroplasticity. And before I show you all of our fancy measurements of how to see the deepness, how deep we reach the neural tissue with electrical fields, well, the same has been done with light therapy. These are cadaveric models. In this one in particular is interesting because the the brain was already fixed with formalin. So anybody who has exposed to cadavers who were resected with alcohol-based substances, the tissue becomes very hard. So even if they were able to detect the absorption of light at that level, and as we can observe here, is because really the light, it had a deep penetrance. And also when they use the nasal probe, I think this is not new for you guys, there is also evidence that yes, the light, it also penetrates the head. What we know, at least I'm very familiar what happened with tDCS, is that it decreases the cortical excitability by facilitating LTD-like plasticity. So as opposed to nodal stimulation, which potentiates long-term potentiation in this case, here LTD-like plasticity will down-regulate the NMDA receptors and will facilitate the permeability to chloride and magnesium. Magnesium by itself, stabilizer of the membrane, the neuronal membrane. So it's reaching this balancing excitability. We know that both techniques, they increases the production of neurotrophic factors, increases the blood flow, and again, in any neurological condition other than brain tumors, if you increase blood flow, it usually has a very positive effect on that. It also being shown that it promotes neurogenesis and synaptogenesis, and particularly for the light, its own anti-inflammatory properties. So what we know, at least in the functional connectivity of kids with autism, is that they show this increased connectivity, this hyperconnectivity that leads to neural fluctuations. So remember those bursts of beat activity in the frontal area? These are fluctuations in the excitability of the brain, and there is basically this imbalance. So when you try to compare with other kids, there is a clear hyperconnectivity in all these networks that are associated with high cognitive functioning. So we at least can assume that what we did in some way modulate this hyperconnectivity, but also, at least for the case of tDCS, it also changed that imbalance in the cortical excitability. So in neurological rehabilitation, our main goal is try to basically facilitate a functional connectivity of different systems. They are integrated in what we call a global space. So kids with autism, for example, here the perceptual system will be hyper-connected, but not only here, other areas of the brain that are not functional because it creates a lot of aberrant plasticity, as we call it. So this will be an aberrant plasticity. It also had a deep impact in how these neurons basically process the information. So the arborization that we observe as a positive plastic change after insult, in autism, there is an excess of dendrites. There is an excess of the spines, the selective spines that will connect with other neurons. And it tends to be a hyper-consolidation of the synapses by literally cell-adhesion molecules that will keep those synapses kind of perpetuating the circuit.
Leon, we have 1 minute.
Yeah. So the light, basically, we can assume, at least based on this case, that it has an impact on the tissue. That impact, it also facilitates the release of trophic factors. At least at the mitochondrial level, there was energy production and increased synaptogenesis, so modulating basically the neural networks, and this obviously have an effect on the behavior of this patient. So as a clinician, I was like, yes, good for her. But as a scientist, I have a lot of questions and doubts. So this is why right now we have this ongoing clinical trial in Spalding. Now with younger kids, these are for kids 5 to 12 years old. Basically, we are trying to replicate the Cuban study in a multi-center trial. We are enrolling. So far, things are going good, not side effects so far. And I hope at least in 1 year that we expect to finish this study, we will have some valuable information for you guys. Overall, this is a clinical case that was, fortunately for the kid and the parents, we observed good results. As I mentioned before, these are confounding results because we use stimulation, but I'm pretty sure that the light by itself, the laser in this case, have also a great impact in this, in the readability of hope. So, and this changed completely her status even now, 1 year after, well, now 2 years. So with this, I just want to thank you. Particularly thank you to my staff at Spalding, Paulo Teixeira from the Neuromodulation Center, and all the people that are collaborating with us. So thank you so much.
Thank you, Leon. This is a fascinating case. I'm very excited about these opportunities of combination. Like we presented a case a few weeks ago on TMS and tPBM, and today tDCS and tPBM. Also, the young age of the child and the good tolerability, even in addition with tDCS, is very important, and the long follow-up you're referring to, which is also very encouraging because we lack this long-term data. Thank you again for presenting. I know some people might have to stop now, but if we might go on for 1 or 2 questions, very quick question, if anyone wants to follow up.
I have a quick question.
Sorry.
Oh, sorry. You used, oh, mine's really fast. You used zirconia laser. Aren't those pulsed? Can you tell us, was there a pulse rate you used with the zirconia laser?
These are pulse, and it has two sources. So I'm not sure. I'm not sure about the frequency of each of these diodes, but they are pulsating at different rates. So one is low, but you can actually see it. The other one is very fast because you basically see the constant beam there. But there are 2 frequencies involved. I don't remember in the top of my head, but at least one it should be between 10 and 20 hertz because it's
You can see it.
Similar.
You cannot see the pulsing. Is that it? You cannot see the pulsing on the other one.
And the other, no, it's too fast.
It's higher. Okay, thank you.
A similar question. Sorry for the time.
Yeah.
What wavelengths? I may lost. I may not catch. So what's the wavelengths you use for those laser light?
650, I think.
So just one wavelength or 2?
One.
One.
As far as I know, one.
650.
635, I thought he said. I thought he said 635 in the slide. Whatever. Okay.
But it was red light, and yes.
The red light, yes. This is red light. Is
now if
635.
If I may, now for that tDCS phantom, did you really physically made the phantom, not just a computer simulations?
No. We did a phantom.
Okay, I will check that paper. Thank you.
We basically build up every intracranial structure. And this was a protocol funded by the US Air Force. They were very interested about the whole point of this was to get an optimization of the electrode montage, how to get to deeper structures. So yeah, the reference is there. I will just put my name and there will be. And then we replicated the same study, the same principle, but in a bunch of healthy subjects using the same montage and the same electrode with real oscillating brains.
We'll see. We can add something that takes care of the light. That would be great. I mean, I'll learn.
In theory, if you can measure electrical fields, you can also detect lights if you use the right sensors, right?
not really. The materials have to be matched with the tissue optical properties rather than the electrical properties.
There are standard values, at least from the physicists from the US Air Force, they agree with that. So there are standard physical characteristics of the material that they will give you as a reference. So in the building of the phantom, if you follow those, it's kind of following the physical characteristics of the human tissue.
Got it. Thank you.
Alrighty. Thank you all again. This was a fascinating presentation, and we'll see you soon. Take care.
Bye.
Bye.
Bye. Thank you. Great presentation. Thank you.
Cheers, bye.
Yeah, thank you. Very helpful.